Hello, I'm Eric Kazarian, a professor of head and neck surgery at the David Geffen School of Medicine at UCLA and past president of the International Surgical Sleep Society, the world's primary organization dedicated to sleep surgery. I've spent my entire career in this field, focusing on the surgical evaluation and treatment of obstructive sleep apnea and snoring, and I want to share my approach with you. During my decades of work in sleep surgery, I've had the opportunity to conduct many research studies. My research is currently funded by the National Institutes of Health, and I also work as an advisor consultant for a number of companies in this area. I will be sharing information about my research and also discussing the treatments sold by Inspire Medical Systems with whom I have been involved in the past related to their research. My background starts with being born and raised here in Los Angeles. After that, I have lived in a number of places, starting with college in Massachusetts at Harvard, graduate school at Oxford in England, and then medical school at the University of Pennsylvania in Philadelphia. I returned to the West Coast for my training, first in Seattle at the University of Washington, then to the Bay Area for a fellowship in sleep surgery at Stanford, and then joining the faculty for 9 years at the University of California, San Francisco. I moved back to Los Angeles to join the faculty at the University of Southern California, where I worked for 10 years before then coming here to the University of California, Los Angeles. I'm board certified in 2 fields that are directly relevant to sleep surgery: head and neck surgery and sleep medicine. Taking care of patients with snoring and sleep apnea requires a broader understanding that goes beyond just performing a surgery properly, and this is why this dual training experience is so important. My background in sleep surgery began long ago as a medical student, where I was intrigued by the fact that this was a new field with many important questions that needed answers. I love my work because snoring and sleep apnea are common, fascinating, and challenging problems that can affect your health, social relationships, and ability to get a simple good night's sleep to get the most out of life. Most people have an overly simplified view about surgery for snoring and sleep apnea, thinking one treatment works for everyone or that surgery does not work. Both of these are not true. My goal is to help you understand my approach to making informed decisions with my patients about what treatments might work best for them. I'm committed to providing state-of-the-art patient care and advancing the field with research and training of other surgeons in this country and around the world. In this video, I will talk about obstructive sleep apnea, discuss many obstructive sleep apnea procedures and the outcomes that we see with them, and then tie it all together with what I think is the key, which is obstructive sleep apnea surgical evaluation. Obstructive sleep apnea is symptomatic, repeated upper airway obstruction occurring during sleep. It's diagnosed with a test called a sleep study, which could basically look at breathing patterns while someone is sleeping. One of the key results for obstructive sleep apnea from the sleep study is the apnea-hypopnea index, the number of times per hour of sleep where someone is having blockage of breathing. While some blockages occur naturally and can be within the normal range, what you see there are different levels for mild, moderate, and severe obstructive sleep apnea. Now, what we care about when treating a patient is not so much a number on a test, but really how it affects the patient and those who love them. So, of course, there's snoring that's commonly involved with sleep apnea, which will disrupt others. But for the patient that has sleep apnea, there can be health-related consequences, primarily cardiovascular effects like high blood pressure or the risks of stroke or heart attack, and possibly some endocrine disturbances, something called insulin resistance, that can occur in severe obstructive sleep apnea. There also could be disruption of sleep that leads to behavioral consequences, things like fatigue, sleepiness, difficulty concentration, or other impairments that really just prevent you from getting the most out of life. It's important that obstructive sleep apnea is very common. This is the best study estimating how common it is both in the US and in countries around the world. And you can see that in the US, across all severities of sleep apnea, it's estimated that over 50 million adults have this problem. And even if you limit that to moderate to severe obstructive sleep apnea, we're still probably talking about more than 20 million American adults. You see there the numbers for around the world, incredibly common, almost 1 billion individuals with all severities of sleep apnea and 400 to 500 million with moderate to severe sleep apnea. So when it comes to treatment, they fall into four basic categories. The first category of behavioral measures includes weight loss, avoiding sleeping on your back, and then avoiding alcohol or other sedatives before bedtime. Positive airway pressure therapy, which CPAP is the most common approach, shown here on the upper right. It basically involves an air blower that can sit on your nightstand next to your bed and blow air from the machine through a tubing to a mask. Here's one that would fit over the nose, but it's blowing air into the body to open up the pathway for breathing and prevent the blockage of breathing that is what is characterized as obstructive sleep apnea. Surgery is designed to physically open and stabilize the breathing passages, and there are specialized mouthpieces called oral appliances. One is shown here on the bottom right. They can work well for some patients also by opening up their throat and stabilizing it. For adults, the common role of obstructive sleep apnea surgery is for those who don't do well with positive airway pressure therapy. And different studies provide different estimates of the proportion that has low adherence or benefit, but 30% is sort of a number that's commonly used in describing how common it is for people not to do well with CPAP. And for them, in addition to all those behavioral measures, their options are no other treatment, thinking about surgery, oral appliances, or maybe combination therapies. And of course, our goal is to improve the apnea-hypopnea index, the number of times per hour with blockage and breathing, but also the signs and symptoms of obstructive sleep apnea, whether they be the snoring, the disruption of your sleep, and all those consequences that occur, and possibly improve health. Anatomic evaluation is the key for surgery results. And what you can see here is that at nighttime, as patients are breathing at night, air is coming easily through the nose, through the throat, and into the lungs. And you have three different areas where blockage of breathing can occur. The nasal region, this palate region behind the roof of your mouth, what we call the tongue region, which is the area down lower in your throat. And we treat the breathing pathway a little bit like a plumbing or an engineering problem, that you have to figure out where it's blocked, which is the key to anatomic evaluation, but you figure out where it's blocked and then open that up. For the nose, there is a long list of possible reasons why you can have blockage in this nasal region, shown there in the column on the left. We're not going to go into any sort of detail, but you can see that there are a number of non-surgical as well as surgical options that can treat the nose. In summary, in terms of isolated treatment of just the nose, it can have a lot of benefits. It can improve nasal obstruction, both improving your ability to breathe through the nose during the day as well as the night. That has been shown to improve sleep quality and actually improve insomnia, the difficulty initiating or maintaining sleep. For those with snoring who have nasal obstruction also, they have snoring but no sleep apnea, you can actually improve and possibly resolve their snoring. But if you have moderate to severe obstructive sleep apnea, treating the nose alone has a relatively low likelihood of clearing up the problem itself. However, there are some important benefits because opening the nasal airway can improve your comfort with CPAP and so improve your ability to tolerate it and do well with it. If you're thinking about treatments like oral appliances or surgery of the throat, what we call pharyngeal surgery, getting the nose open can be a very important part of it. So by itself, it may not be sufficient, but it often is necessary to be able to breathe well through your nose. So when it comes to thinking about treatment for the throat, not all patients with sleep apnea are the same. They differ. And that patient on the left-hand side, the far left, that's sort of the stereotypical middle-aged overweight man, very different from the patient in the middle, sort of a thinner woman who has a totally different cause for their sleep apnea, which as it turns out is much worse than the patient on the left-hand side. When we look in the mouth, which is what we do as part of our anatomic evaluation, the upper right image is someone with very small tonsils, whereas lower right is someone with markedly large tonsils, what we call kissing tonsils, because these are physically touching in the middle of the back of their throat. So what we do is figuring out what's causing sleep apnea with our examination on all levels. For a long time, it's been known that as people gain weight, it's a huge risk factor for developing snoring and obstructive sleep apnea. This was probably the most elegant study that looked at why we see not only that gaining weight being very important, but actually why some people who are quite overweight don't really have much in the way of sleep apnea. This was a carefully done study involving what's called a case control study of those with higher body mass index, which is this very crude measure of height versus weight. And what they did was they took those with high body mass index and had 90 with sleep apnea and 31 without. Now, because there can be a lot of differences between people with sleep apnea and those without, what they did was, among those people, they found 18 that were similar in terms of their body mass index, their age, their sex, and their race, and compared them specifically. And what they looked at was the tongue, as well as what's called the masseter muscle, the muscles on the sides of the face, and with a sophisticated technique called Dixon imaging, which is able to look at fat specifically. And what they showed was it was true in the tongue, but not so much in these muscles on the side of the face. The fat shown in yellow was a big explanation for why someone had sleep apnea or not. Basically, if you have fat storage in this part of your body, you're more likely to have sleep apnea. That person on the left-hand image had a body mass index of 34, but had very significant sleep apnea. Apnea-hypopnea index of 59, whereas the person on the right, who had a body mass index of 35, actually a little higher, had pretty much very mild sleep apnea, apnea-hypopnea index below 10. So again, fat storage, not just gaining weight, is probably true for muscle mass as well, but that plays a huge role in not only predicting whether someone has obstructive sleep apnea, but as we'll see later, results of surgical treatment. But you'd like to have a test that would be able to identify the site or multiple sites of obstruction. And ideally, you'd like something that was easy, meaning technically simple and not invasive. Low cost is always good. With obstructive sleep apnea, we're looking at people while they're breathing and while they're sleeping, so you'd like to have a test that could capture that. But the most important thing is getting accurate information that is associated with treatment. And here we're talking about surgery. So some of the things that have been around for a while include body mass index, which can be actually very helpful, but not by itself. Sleep study results, it turns out, are not that helpful. You can't take someone who has milder versus more severe sleep apnea and use that to guide the kind of surgery you might offer or where you might focus your efforts. Tonsil size, we saw two examples of sort of the extremes of small and large tonsils, so it can be very helpful, but for most patients it's not enough on its own. It turns out lots of imaging studies like CAT scans are not all that helpful. So what is helpful is something called drug-induced sleep endoscopy. It's an evaluation technique that was described long ago in multiple centers in Europe, and the first publication was in 1991 at the United Kingdom. It was popularized in other countries, especially in Europe, but it's now used around the world and especially more common now in the United States. The basic idea behind it is to be able to look in the throat to see what is physically causing blockage in breathing as patients are sedated. Because putting a little telescope through the nose and the throat is not so comfortable when you're awake or even when you're trying to fall asleep naturally. So going to the operating room, have patients receiving some sedation, allows you to reproduce the breathing patterns that someone has, that we know they have on a sleep study in natural sleep, but do it in a way that allows us to look inside. And with some European colleagues, I developed the VOTE classification system to provide some standardization as people talked about drug-induced sleep endoscopy and allow us to compare findings and outcomes actually across multiple centers. Now the nice thing about being sedated is that we can do different maneuvers while we're looking inside the throat. If patients are mouth breathing, we can close their mouth. We can also lift their lower jaw forward, sort of simulating what these oral appliance mouthpieces might offer. And we actually can administer CPAP and explain why people are or not doing as well as we would like with CPAP in certain cases. So this is this VOTE classification that is an acronym including the 4 key structures that play a role in obstructive sleep apnea. V is for velum, which is the palate area. And so it's the area up high in the throat, behind the roof of the mouth. O is for oropharyngeal lateral walls, basically the sides of the throat. T is for tongue or tongue base. And E is for something called the epiglottis, which is basically a trapdoor that goes over your voice box so that when you swallow, things don't go down the wrong way. And during drug-induced sleep endoscopy, for each of these structures, we can characterize the degree of obstruction, whether they are or are not playing a role in blockage and breathing. And in certain cases, there can be different directions that this blockage of breathing can occur. For example, behind the soft palate, there can be front to back blockage, antero-posterior, side-to-side blockage, lateral, or a combination of the two. So I've got some videos for you. Here is for the velum or palate. And the orientation is at the top of the image is the back of the throat. This is the soft palate and the uvula that hangs down in the back of the throat. This is someone that has a relatively open area for breathing, but of course you can see the vibration of the soft palate. That's creating snoring sound for others. Again, the back of the throat on the top. This block of breathing is occurring front to back and side to side, and it's completely blocking the breathing pathway. So this is what's called complete concentric collapse. We don't do it very often, but if someone has big tonsils, but you can see the edge of those big tonsils there, the throat never really opens up all that much. Yeah, it's sort of a fun video because the uvula, the thing that hangs down the back of the throat, comes and says hello right about here. So, O is for oropharyngeal lateral walls, the sides of the throat. Again, the top of the image is the back of the throat. Here's the tongue and the epiglottis, and what you see is those are not falling back. Actually, it's really just the sides of the throat that are caving in and blocking breathing. And it turns out this is not such a great thing in terms of looking at surgical outcomes. Similar situation. Again, the tongue down here. This epiglottis, not falling backwards, really the sides of the throat caving in. T is for tongue. So this is the back of the tongue, that bumpy surface. It's a little bit blocked by the roof of the mouth, so the telescope is advanced. And what you can see is that the tongue is really falling back completely to block breathing. And of course, these structures can play a combination role. So here the tongue falls back and pushes this epiglottis against the back of the throat. But sometimes the epiglottis falls back on its own. The tongue here is almost out of the field of view, and the epiglottis here just falling back on its own. I mentioned these maneuvers. This is someone with mouth opening during drug-induced sleep endoscopy, and the tongue here is falling back to block breathing fully. And so what we'll see here is just closing the mouth. This is obviously a dramatic example, but it can open up the pathway for breathing nicely. So we kept the mouth closed, just literally closing their mouth manually. And now we let go, and the tongue just fell back again. Here's a different patient that had the soft palate here blocking things, narrow space for breathing there in the middle. And we lifted the lower jaw forward to simulate the effect of this oral appliance, also known as a mandibular advancement device or mandibular repositioning appliance. Of course, I'm showing a dramatic example, but the airway can really open up for many patients, suggesting this patient would be a very good candidate for an oral appliance. And we sort of let up a little bit on how much advancement of the lower jaw. A little bit less. And then we let go fully. So, in terms of the wide array of surgical procedures that exist, we have a number of them that can treat the palate region there on the left-hand side. The upper right, a number of procedures that focus on the tongue region. And then some procedures that can treat both regions of the throat. First, palate procedures. I'm going to describe those that are shown there in red. There are other ones that can be very helpful in certain patients. For a long time, the primary surgery we had for obstructive sleep apnea was the uvulopalatopharyngoplasty, or UPPP. Like all these things, they have medical names that are a bit of a mouthful, no pun intended. So what this procedure involved was removing tonsils in patients who had them and removing the uvula that hangs down on the back of the throat and part of the soft palate. Taking the patient on the left-hand side to to look more like the right-hand side. And of course, what you care about is not so much what it looks like when you look in the mouth and see this nice and open, but what you care about is what's happening behind that soft palate. When we sleep, the muscles in our body are mainly relaxed. And so that is what allows these muscles that surround the throat to fall back and block breathing. And what you did with this procedure was removing some tissue to prevent that blockage of breathing from occurring as muscle relaxation happened in sleep. Well, the results for this were okay, especially if people had big tonsils, but they weren't as good as we would like. So over the years, a number of other techniques that have evolved based on not so much removing tissue, but moving things around and stabilizing them. One of these was the expansion sphincter pharyngoplasty procedure, which had a number of modifications. In the literature, there's a couple of different names that exist for it. But this procedure is somewhat similar in that it starts with getting the tonsils removed, but instead of just cutting things out, what you do is you take this muscle, it's called the palatopharyngeus muscle, behind the tonsils, you cut it down low, and you effectively bring it up, out, and forward by tunneling it underneath the surface. You can see that on the left-hand side of the drawing. And by anchoring it in place, what you're effectively doing is taking the soft palate and pulling it forward so that when we have muscle relaxation during sleep, it's harder for it to fall back and block off your breathing. Well, this takes a little bit more time, it's a little bit more difficult, but it turns out we do it because it actually works and has better results. So here's the first major study of this technique. It was a randomized controlled trial, about 20 patients who had this new technique compared to about 20 with the previous technique. They all had tonsils, but they were not markedly enlarged. They were what we consider 1+ or 2+ tonsils, and they did not have notably elevated body mass index. Maybe they were in the overweight range, but was not higher than a body mass index of 30. And what they showed was with the new procedure, you actually decreased the collapse of the sides of the throat, what are called the lateral walls, but importantly, you had higher success rates. And so with the traditional approach, you had a 45% response rate, basically cutting the apnea-hypopnea index of at least in half, also to a level below 15, 45% response rate versus 78% response rate with this newer technique. Again, making it worthwhile to spend the extra time. Another technique that I use actually a little bit more commonly now was developed in Australia. It started out similarly and the tonsils were removed. Sometimes there's a collection of fat above the tonsil. You can see in the middle drawing, you would remove that collection of fat called a fat pad. But again, you take the muscle that's behind the tonsils, cutting it down low and bringing it up, out, and forward. Instead of doing it through a little tunnel, you actually just make a little cut in the muscle in front of the tonsil so that you can then sew it together, shown here under the surface, followed by a surface layer of stitches. I like this technique. I think it's straightforward, but I also like it because the combination of this with something called tongue radiofrequency that we'll talk about later showed pretty impressive results compared to observation alone with the publication in JAMA, the Journal of the American Medical Association, which is one of the top medical journals in the world. And with this kind of surgery, this combination of procedures, the apnea-hypopnea index went from 48 to 21, as compared to observation where it went from 45 to about 35. Those are procedures focusing on the soft palate, the back of the roof of the mouth, but sometimes people have some narrowing behind the palate because the hard palate extends a little bit too close to the back of the throat. And what would be helpful there is to remove a part of the bone and pull everything forward, sort of like you see here, and it turns out that you can do that. It's a surgery that involves going through the mouth and opening up the roof of the mouth, the bone of the roof of the mouth, and removing part of it so that you can then bring the soft palate forward with that portion of the hard palate. When there seems to be blockage in breathing in the tongue region, there are a number of procedures there on the left side that focus specifically on this area. And there are a couple of approaches that treat the tongue region, but can also treat the palate region as well. For the tongue region procedures, we'll discuss those listed there in red. Radiofrequency is a controlled cauterization that has been used for about 50 years to treat many areas of the body. When it's used to treat the tongue, it involves a handpiece with a needle tip on the end that can be placed into the back of the tongue, the front of the tongue, and even the sides of the tongue. And by heating up that tip of the device, you create a little damage in the tongue. The human body heals from that and forms some scarring, some fibrosis. And during sleep, while muscles relax, scar tissue does not relax. So what this does is effectively tightens up the tongue so that when we have muscle relaxation during sleep, it's harder for the tongue to fall back and block off breathing. The major tongue muscle is called the genioglossus muscle, and it attaches on the inside of the lower jaw, an area about as big as 2 fingertips. So the genioglossus advancement procedure says, well, why don't we pull that anchor point for the tongue forward? And you do that by making an incision inside the lower lip, lifting the muscle off the jawbone and cutting a little rectangular window to capture that anchor point. You pull it forward and you put a little screw to hold it in place, but again, as you have muscle relaxation occurring during sleep, it's harder for the tongue to fall back and block off your breathing. Sometimes blockage in the tongue region is related to enlargement of the tonsil that we all have on the back of our tongue, called the lingual tonsil. And if that's the case, well, making that smaller can open up space for breathing, as you can see comparing the left-hand drawing to the one on the right. When you have the epiglottis playing a role, there have been a number of approaches that have tried to treat that. One of these is the hyoid suspension procedure. There's a bone in our neck that's got a horseshoe shape to it. It's called the hyoid bone, shown here as well as on the top up there. And it has a ligament connecting it to the epiglottis. And this procedure involves taking that bone and pulling it forward and anchor it with some stitches there so that when we have muscle relaxation during sleep, this bone and everything attached to it is less able to fall back and block breathing. One of the direct effects is pulling the epiglottis forward. Another epiglottis-focused procedure is the epiglottis stiffening operation developed in Italy over the past few years. In some cases, the epiglottis can be displaced posteriorly. We saw that in some of the videos. And this procedure involves going through the mouth and cauterizing an area between the tongue and the epiglottis, roughly here, so that as our body heals from that, it pulls the epiglottis forward, less able for it to fall back and block breathing. Jaw advancement, a procedure I used to do but don't do currently, involves making cuts in the upper jaw and the lower jaw and bringing them both forward. Because muscles are ultimately attached to bones, in most cases, this actually opens up space for breathing in both the area of the palate region as well as the tongue region. We work with oral surgeons all the time. Patients are a good candidate for this kind of a procedure. Refer them, given that I don't do this anymore myself. So in terms of outcomes, looking at combining palate and tongue region procedures, this was a very old study that had far from perfect evidence. And what we saw at the time was there was a wide array of success rates, but importantly, the predictors of results, at that time what we had was pretty much body mass index to guide us. And basically we told people that a higher body mass index was bad for surgery results, whereas lower body mass index was good. But we really needed more than just that. So as drug-induced sleep endoscopy became more widespread, and as we started having a chance to really look at those in detail, Catherine Green, who's now at the University of Colorado, Denver, who did her fellowship with us when I was at USC, we undertook a study to look at whether drug-induced sleep endoscopy findings that we have from before surgery are associated with results of surgery. And so this was a multi-center study involving 14 centers in the US and some around the world, 275 study participants. They had no markedly enlarged tonsils, so they either had no tonsils and had them removed previously or were small to normal sized tonsils, and they could not have had previous surgery other than possible tonsillectomy. What we did, and took a lot of time, was that for 4 surgeons, we looked at all of these videos without knowing what kind of surgery someone had, without knowing what the results of surgery were had, and we scored it according to the VOTE classification, and then we also looked at if we felt that there was a key structure that was playing a role in their obstructive sleep apnea, a so-called primary structure. And importantly, we had a variety of findings. And this is actually really good when you do research, because then you can compare people with different kinds of preoperative drug-induced sleep endoscopy findings. And what we found using a definition of response of, again, a 50% drop in the apnea-hypopnea index to below 15 events per hour, we found that, shown here in red, for those with moderate to severe obstructive sleep apnea prior to surgery, if you had collapse of the sides of your throat, that was actually bad. The odds of response, the odds ratio was cut in half. And similarly, if you had complete tongue-related obstruction, you also cut your odds of response in half. So those were both bad for outcomes. Emily Comesso, who's now a sleep surgeon at Duke, who did her fellowship with us at USC, she added this finding that we can get from a wake physical exam called palate shape, described by Tucker Woodson, who's at the Medical College of Wisconsin. What palate shape involves is getting a sense of what kind of narrowing people are having behind the palate. Some people have narrowing because the hard palate, like we saw previously, the hard palate extends to be too close to the back of the throat. Some people have narrowing because the hard palate is open, but there's a bend in the soft palate, and at the bend, it's narrow. And then some people have the soft palate that sort of what we call oblique, that goes at more angle, gradual angle like that. And so what her study, again, looked with 3 blinded reviewers, showed that overall there was no association between different findings related to palate shape. However, if you had soft palate surgery alone, isolated soft palate surgery, if you were narrow at this genu or bend of the soft palate, actually your odds of response to soft palate surgery were lower, suggesting that soft palate surgery might work better on the area below the bend in the soft palate. And interestingly, if you had some narrowing on a side-to-side pattern, it doesn't show up on this drawing, but if there was some narrowing from the sides, some of these repositioning procedures, which has sort of become contemporary soft palate surgery, but the repositioning procedures may actually work very well with that because the response rate was actually higher if we're having collapse there from the sides of your throat. The upper airway stimulation technology from Inspire Medical Systems can treat blockage of breathing in the tongue region, but it has other benefits as well. So Inspire therapy is a fully implanted technology that involves surgery to place 3 components of the system in the body. There's a pulse generator that's placed on top of the pec muscle on the upper chest and 2 wires that connect to it. In its current version, there's a sensing lead that goes underneath the pec muscle in the chest that's used to sense breathing, although the redesign of the generator that should be available in not too long may make the sensing lead not needed because the function may be within the generator in the new design. But there's a stimulation lead that connects the generator to a nerve in the neck called the hypoglossal nerve, so that when a patient turns the system on when they go to bed, the generator can deliver mild stimulation to the hypoglossal nerve, effectively moving the tongue forward as the patient takes a breath every time. So the major study of this, called the STAR trial, was published in the New England Journal of Medicine, which again is one of the top medical journals in the world. It was a single-arm study involving 12 centers in the United States and Europe. Of course, they looked at safety and showed that it was safe, but they also looked at efficacy with 2 measures of obstructive sleep apnea severity, the apnea-hypopnea index and a similar metric called the oxygen desaturation index. They also looked at other measures of quality of life as well as sleepiness, because of course we care about those very much. All patients that were in the study had failed CPAP. They had moderate to severe sleep apnea. They did not have markedly enlarged body mass index. They had a wide age range, and importantly, prior to being eligible for the study, they could not have that complete concentric collapse related to the soft palate, what I showed you on one of those videos. So they had sleep endoscopy before they were determined to be eligible for the study. So what were the results? So for the apnea-hypopnea index there at the top, on average, the number went from 32 to 15. Not a perfect result in everybody, but a pretty impressive improvement. And the median scores, which is sort of more of a typical patient, went from 29 to 9. Similar results were seen across other measures that you can see here. This is what actually, these impressive results are what led to the publication, again, in the New England Journal of Medicine. What was just as important for me was a second study that they did that was focused on the first 46 study participants that did really well. What they did was they had people at baseline and then at 12 months, again, only the ones who did really well, with a sort of roughly from 30 events per hour down to like 5 to 10. And they did something that wasn't very nice. They turned the device off in half of them. And so, first of all, they let the device on, the system on. They had maintained their improvements in sleep apnea. But when they turned it off, sleep apnea came back. And that's there in the light shaded bars, suggesting that it wasn't something random that happened. They didn't just randomly lose weight or have something else happening, that it was directly a result of treatment with the therapy. Similar results were seen with the other measure of sleep apnea severity, as well as these questionnaires that look at sleepiness, as well as sleep-related quality of life. And importantly, they didn't just look at 12 or 18-month results, they looked at 5-year outcomes. And what you can see is the results are relatively consistent, whether we're looking at sleep apnea severity, this apnea-hypopnea index in the upper left, sleep-related quality of life, or sleepiness, and then different measures of response rates, but the one for the apnea-hypopnea index is in blue, and showed pretty consistent results of about 70% response rates. Not perfect, but 70% and holding up nicely over time of 5 years follow-up. Phil Hewitt, who's now at Mass Eye and Ear in Boston, was a fellow with us at USC, and we did a similar study based on the fact that, to ask the question about whether sleep endoscopy findings are associated with outcomes of the Inspire upper airway stimulation system. As I mentioned, drug-induced sleep endoscopy is required before people can be implanted with this therapy. And the primary use is to screen out those who have that complete concentric collapse related to soft palate, which turns out to be roughly about 30%. And for those who are eligible, what we effectively were doing was telling people they had about a 65-70% chance of having this work for them. But what if we could do better? What if we could identify those who might have an 80% response rate compared to those with 60% or maybe even lower response rates? Well, it turns out we can't. So what we did was we had 10 centers, 343 study participants, and we used what is not a perfect way to judge responses, but it was from what's called a titration sleep study, where patients who were implanted with the Inspire system, about 3 months or so after the implant procedure, they would come into the sleep lab and get their system sort of tested to see how good a response you could get across different settings. It's still done quite commonly, although not universally. But what we looked at under ideal situation, what was the ability for patients to respond well to Inspire therapy? So we had preoperative drug-induced sleep endoscopy videos, similarly absent or not enlarged tonsils at least, and no other previous surgery. Overall, when you put everything together, there weren't any clear associations. However, for those with moderate to severe sleep apnea, on looking at specific single variables, if you had full collapse, complete collapse related to the sides of your throat, your likelihood of response was lower, about 60% versus like 75%. Importantly, if you had complete collapse related to the tongue, what we call T2, which was actually bad for other kinds of surgery, you actually did really well with Inspire. In essence, it's not much of a surprise, because if that was sort of the key part of what was causing your sleep apnea, you're directly treating that with the Inspire upper airway stimulation system. And these kinds of changes were echoed in the people that had a primary structure clearly contributing to their sleep apnea. Response rate, if the sides of your throat were the primary structure, about 60% versus 80% if the tongue was the primary structure. Serge Kodarasetti, who was a fellow with us, sleep surgery fellow with us at USC, now at Kaiser Northern California, he looked at this palate shape with other reviewers in a similar fashion. And what he found was that if you were narrow at the hard palate, looking a little bit like this, there was a lower likelihood of responding well to Inspire upper airway stimulation. Your odds ratio was cut in half. And especially true if you had this narrowing and complete collapse of the sides of your throat. It wasn't very common, but there were only 2 out of 9 people that responded well to Inspire therapy, and whereas the results weren't so bad if you had collapse of the sides of your throat without this hard palate narrowing. So these are things that we use all the time to take care of patients, and it funnels into this paradigm, the structure-based approach that I use in taking care of patients when we're considering obstructive sleep apnea surgery. So it starts with the first column there, what structures are playing a role, and taking these procedures and trying to match them to what's going on for individual patient. For the velum, if it's the soft palate, there's a number of techniques that can be done with soft palate surgery, whereas if it's the hard palate, we think about palatal advancement. If it's the oropharyngeal lateral walls, the sides of the throat, not totally clear, but some people may respond to some of these procedures that may help stabilize the sides of the throat. Sometimes we think about oral appliances or jaw advancement surgery. There are a number of tongue-focused procedures. Some of them are more involved, some are less involved. We have upper airway stimulation, which can treat the tongue, but in many patients can actually treat these other structures as well. A few options for epiglottis-directed treatment, and then those who have markedly abnormal skeletal structure might want to think about jaw advancement surgery called maxillomandibular advancement as a first-line option. But the key is there at the bottom, counseling patients. we have to think about body mass index, our wake examination, as well as findings from drug-induced sleep endoscopy, and putting it together, of course, with patient preferences is so important. In conclusion, obstructive sleep apnea is common with important health-related and behavioral impacts. Patients with poor compliance or adherence to positive airway pressure therapy should at least consider adjunctive or alternative treatment options. Airway narrowing and/or obstruction can occur at 3 levels: the nasal region, which has many sources, the palate region, which is the hard or soft palate, and maybe the tonsils playing a role there as well, or the tongue region, where you have the oropharyngeal lateral walls, the sides of the throat, the tongue, or the epiglottis. And obstructive sleep apnea surgery outcomes are improved with addressing obstruction at the relevant level or levels, because evaluation of the pattern of upper airway obstruction may enable targeted, more effective treatment of obstructive sleep apnea, as well as the development of new devices or procedures. What I tell surgeons is that poor outcomes, we've always considered them a failure of our hands, our surgical technique, or our skill as a surgeon, but really, maybe our heads, because the selection of appropriate procedures may be as important as performing the procedures properly.